Hi, everyone. My name is Dr. Kanjilal. I am an Associate Medical Director of Microbiology at the Brigham and Women's Hospital at Harvard Medical School and a lecturer in the Department of Population Medicine. And I'm going to talk to you today about a broad overview of serologic testing for SARS-CoV-2. And I have no disclosures to report. So I'd like to start this talk by first addressing a very common misconception among people when they think about serologic tests versus PCR tests, which were talked about in another section of this talk. And the fundamental difference is that molecular diagnostics are actually looking for the actual virus itself, whereas serologic assays are looking for the humoral or the antibody immune response to a virus. And the table below highlights some of the differences between the two tests. So for serologies, the target, as I said, was looking at the antibodies to the virus, whereas molecular tests such as PCR are looking for viral nucleic acid or viral antigens or proteins. And in general, serologic tests are run on blood, and separated into serum or plasma, whereas molecular tests are run on upper and lower respiratory tract specimens, which are generally collected using nasopharyngeal swabs or other such collection mechanisms. The use for serologies at the current moment are, one, to diagnose active infection with the caveat that this is an off-label use, but it can help in cases where PCR is negative, symptoms began some time ago, roughly at least 7 days, and suspicion for clinical infection with COVID is still very high. Primarily the use case serologies right now, however, will be to determine prior infection, and there are many other potential use cases that are on the horizon but not ready at the current moment. PCR, on the other hand, really is solely used to diagnose active infection right now. And the types of serologies right now include ELISA assays, which I'll talk about, neutralization assays, and the molecular tests really focus on mostly PCR, but also include loop-mediated and isothermal amplification assays, CRISPR diagnostics, and more recently, some antigen detection assays. So a critical component of testing for SARS-CoV-2 relies on understanding where in the illness course the patient is with respect to the onset of symptoms. And so this is just a schematic of that is commonly used for describing this phenomenon. And the choice of which type of assay to use depends heavily on where the person is along this timeline. And so within the first 0 to roughly 7 days of illness, the levels of RNA in active infection are quite high and drop off precipitously as the immune response begins to pick up around day 4 or day 5. And that goes the same for viral antigens. And in fact, the peak levels of RNA may actually occur before symptoms occur in the week before and start downtrending once symptoms appear. As shown here, roughly on day 4 or day 5 are when antibodies begin to appear, and IgM is the first isotype to appear slightly before IgG antibodies. IgM then peaks roughly between day 7 and 14 before declining roughly over the course of the next couple of weeks. IgG antibodies appear slightly after IgM, continue to rise through the first 2 weeks of infection, and then plateau and persist for at least 6 to 8 weeks, according to the latest studies, probably longer, although we haven't had enough follow-up time to determine that. And so just to summarize what was shown in the previous slide, in the first 5 to 7 days post-onset of symptoms, PCR or another molecular diagnostic is really the test of choice because you have plentiful virus to actually detect. But starting at around 7 days onwards, antibodies become detectable and can certainly aid in the diagnosis of active infection in cases where the PCR is negative. But at around 2 to 3 weeks post-onset of symptoms, serologic tests become more useful than PCR tests, where the probability of false negativity with the PCR rises precipitously. And in patients without symptoms, which recently has been reported to be as high as 80% of people with SARS-CoV-2 infection, serologies may represent likely the only means of diagnosing prior or even active infection. And as shown, IgM rises slightly before the IgG, wanes roughly by week 3, whereas IgG remains high starting around week 2 and plateaus across the time course for at least 6, probably longer weeks post-infection. So there are multiple types of assays that are currently in circulation. And they can fall roughly into three broad categories, and I'll show each of those right here. So the first one are what we call rapid diagnostic tests, which are also, in this instance, referred to as lateral flow assays. And the diagram here is shown on the right. It's similar to a pregnancy test where a sample is placed in this diagram on the left-hand side of a test strip, and then through capillary action moves right through the test. As the antibodies, if they're present in a patient's serum, cross the conjugation pad, it will come in contact with viral antigens that are conjugated to gold particles. And if present, they'll bind and be carried forward to either the M line, where IgM antibodies to humans are located, or the G line, where anti-human IgG antibodies are located. And then the last line is just a control line to make sure that the reaction proceeded as expected. And so a positive IgM test will have a line at the M end spot and one at the control spot, whereas a positive IgG test will have one at the G line and the control line. And in patients who have both antibodies, all three lines should appear. Below that, I show a very commonly used assay for serologic diagnosis called an enzyme-linked immunosorbent assay, or an ELISA. And there are multiple flavors of this type of assay. I'm showing one on the right here, where if you can imagine that cylinder is a well on a plate, and on the bottom of that are coded antigens from the virus that are fixed to the bottom of the plate in a solid state. Again, the patient's serum is added to the well, and if antibodies are present, they will bind the antigen that is located on the bottom of the plate. And then a secondary antibody is added, which is specific to the primary antibody, which binds to the antigen. And that secondary antibody is conjugated to an enzyme. And when the substrate of that enzyme is added to the well, a color change will appear that can be detected. And this test can be qualitative or also can be quantitative. The last type of assay that is on the market right now is called a chemiluminescent assay. And the principle is similar to an ELISA. However, it's instead of being in a solid phase, it's actually in a liquid phase. And so this is the basis of the Roche-Cobas SARS-CoV-2 antibody assay that I'm showing here. And the principle is shown starting on the left-hand side. Again, a patient sample containing antibodies to SARS-CoV-2 is added to a suspension that contains antigens from the virus, in this case, the nucleocapsid antigen, in two forms. One form of the antigen is bound to a ruthenium molecule, and the other one is bound to biotin. After a period of incubation, magnetic beads that are coated in streptavidin are added to the sample, and any antibody that is bound to nucleocapsid that has the biotin on it will bind the streptavidin-coated magnetic bead. And again, after a certain period of incubation, a magnetic field is applied to this complex, and any beads that are attached to this complex will be fixed, whereas remaining non-specific antibodies will be washed off. And then lastly, an electric field is applied to it such that electrons on the ruthenium molecule will be excited and will emit certain photons of light that can then be measured in a luminescent assay. And so this provides also quantitative measurements. So looking at these three tests side by side, the RDT being the lateral flow assay, or the LFAs, the ELISAs, the chemiluminescent assays in the third column, and on the right are the gold standard neutralization assays. Results for the lateral flow assays are qualitative. They're either positive or they're negative. ELISAs and chemiluminescent assays can be qualitative or semi or fully quantitative, whereas neutralization assays are a quantitative test. The turnaround time here is roughly just minutes with the RDTs. ELISAs typically take a couple of hours. The chemiluminescent assays can be as fast as 18 minutes for the Roche, but generally can take a couple of hours as well. And neutralization assays require days because you are incubating live virus with cells. The throughput of the RDT is relatively low because you can only do one patient per test. For ELISAs, they're considered medium throughput on the order of several hundred a day. And the chemiluminescent assays are high throughput where we can do up to thousands a day. And neutralization assays are very low throughput. They can only do several a day. For the deployment of RDTs, these are really meant to be at the point of care, whereas the ELISAs and the chemiluminescent assays are lab-based. And neutralization assays are really reference lab-based because they involve, again, dealing with live virus, which requires biosafety level 3 containment procedures. Only one assay, which is the neutralization assay, actually detects for the function of the antibodies, which is why they're considered one of the gold standards. And compared to the sensitivity of ELISA, the RDTs typically have lower sensitivity, and the chemiluminescent assays, based on their technological advances, tend to have higher sensitivity compared to the ELISA. And so what targets are these tests actually looking for? This is just a quick schematic of the virion for SARS-CoV-2. This has been shown before, but to go over quickly, the two immunogens, which are the proteins which humans mount an antibody response to, are the nucleocapsid proteins shown here, labeled as N, and the spike protein shown here, which is what gives coronavirus its name. The function of the nucleocapsid protein is both structural as well as non-structural, but primarily it encloses the viral nucleic acid here, whereas the spike protein is responsible for binding to receptors on human cells that give it the virus its tropism. And the spike protein itself, it has three domains really, the S1 and S2 domains, and then one called the receptor binding domain. And the advantages of the N protein are that it's more plentiful typically in infection and can be relatively easy to produce in large quantities in the lab. However, because it's shared more closely with other related coronaviruses, may be somewhat less specific than the spike protein and the RBD, or the receptor binding domain in particular. The disadvantage of the spike protein is that it's found in lower quantities and can be a little bit harder to produce in the lab. Thus, the choice of assay should depend in part on whether you wish to rule in disease by choosing an assay that is highly specific, such as one that targets the spike protein, or ruling out disease by choosing an assay that's highly sensitive, in other words, targeting the N protein. So there are many assays out there currently, several hundred, in fact, are in circulation, of which only a few are actually approved by the FDA under the emergency use authorization. This is a table of just several of them, courtesy of Dr. Galit Alter. And the performance of these tests varies very widely. And many of you may have seen these headlines across major news outlets discussing this problem. So the one on the right was from the New York Times, discussing an article that we'll go into shortly, but looked at variability across lateral flow assays and ELISAs. And then the one on the left just appeared several days ago in Forbes magazine, talking about false positivity rates in areas where prevalence for COVID is less than 5%. So unless your test specificity is very high, on the order of 99%, your false positivity rate can be quite high. And so to dive into some of the data briefly here, this is an article that appeared on medRxiv a couple of weeks ago from a group out of the University of California, San Francisco, and Massachusetts General Hospital, which looked at 10 different lateral flow assays and 2 ELISAs assays. And these are some of the results that are from this paper. And so this is looking at only the lateral flow assays, and along the rows here correspond to whether the assay is an IgM assay, the combined performance of IgM or IgG, and the IgG specific performance. The y-axis here is looking at the rate of positive samples, and then the columns here correspond to days of onset from symptoms. And so right off the bat, you can see that very early on, the sensitivity of this assay is quite low, which is what we expect based on the antibody response, and then rises over time, peaking roughly at roughly 3 weeks after the infection started. But what's really striking is that among these 10 different lateral flow assays, this is a linear scale, is quite a lot of variability, particularly up to 30 to 40% variability, depending on which assay you use. And these target various, either the N protein or the spike protein. And when looking at the specificity, again, you can see here, while most of them are above 80%, that is not acceptable specificity when the prevalence of a disease is quite low. And the variability, again, between the different lateral flow assays is quite high. And when you actually look at this heat map on the left-hand side here, you can see that a patient sample, when run on one assay, may have very different results when run on a different assay. And so overall agreement here ranges somewhere between 75% and the high 90%. But gives you a sense of the complexity that if you were to actually receive tests from one patient on one of these assays and run it on another assay, it can be hard to predict what the results are going to actually be. And in general, there are many complexities in the interpretation. And as these assays, more and more assays begin to hit approval on the market, it's very important to take a critical look at the quality of the validation that was used to bring the assay to clinical use. And so some points to consider are: one, did the validation study include patients' serum that were infected by the endemic coronaviruses, ones that are in common circulation throughout the world and infect people have antibodies to, the majority of the population have antibodies to it already. And you're really looking here for cross-reactivity between the assay that you're looking at and these other more innocuous coronaviruses. Does the validation study assess the time of the test relative to the time of symptom onset? Because the numbers that are given really depend on that time differential. Does the validation study assess the severity of illness or the immune status of the patient, which both can modulate the degree of positivity for the test? Does it assess for standard interfering substances that can block the performance of the test? And does it assess for non-coronavirus cross-reactivity to other viruses that produce very polyclonal antibodies, such as the Epstein-Barr virus, or other autoimmune factors, such as rheumatoid factor, that can cause false positivity as well? And then critically, it's very important to try to suss out what the quality of the reference comparator is that the validation study used to determine the assay's positive predictive agreement and negative predictive agreement, which are really the terms we use for sensitivity and specificity when there is no established gold standard to compare against. So all these factors really should be taken into account and can lead to quite a bit of confusion in terms of assay interpretation. And so I just want to walk you through several different possibilities for what happens when you get a positive SARS coronavirus 2 antibody result on a patient. The first thing to do is assess your level of clinical suspicion, whether it's high or low. And then the next thing to do is first determine whether they are symptomatic, previously symptomatic, or asymptomatic. And so going down the pathway of high clinical suspicion right now, and if they're currently symptomatic, then it's probably safe to say that a positive antibody test will likely signify that the patient has an active infection, regardless of whether it's IgM or IgG, depending on the onset of symptoms, because both arise roughly at the same time early on. If you have a high clinical suspicion and they were previously symptomatic but currently asymptomatic, it is possible that they have recovered from SARS-CoV-2 infection. And if you have high clinical suspicion and they're asymptomatic, because 80% of people don't have symptoms at all, it is possible that they still have active infection and you need to confirm with the PCR test, or that they have fully recovered and there's no way to really distinguish between the two. Now, if we're looking at low clinical suspicion and they're currently symptomatic, then it's possible that this test has provided a false positive result, which again gets to the issue of having a test run on asymptomatic people in a low prevalence situation. However, there are plenty of stories of people being diagnosed with SARS-CoV-2 in the past or currently that have surprised the clinical teams. And so it is possible that if they are symptomatic, even in low clinical suspicion that they actually do have active infection, you'd be obligated to get a PCR test to confirm or rule out that. If they were previously symptomatic, it could also still be a false positive result, or it could represent that they have recovered from an infection in the past that was not detected. And then lastly, in low clinical suspicion, asymptomatic people, these folks really should not be tested for serologies to SARS-CoV-2 because, again, for reasons of having low prevalence, it is possible that you have a significant chance of receiving a false positive result. However, all of these different pathways are much more nuanced than what I'm actually showing here. I have to take into account the clinical status of the patient, time from onset of symptoms, and many other factors, and uncertainty in the sensitivity of the PCR alongside all of this. And so to me, the perfect serologic test is one that has greater than 90% sensitivity after at least 7 days of symptom onset, has at least greater than 99% specificity compared to a very broad validation cohort that I described in the earlier slide, one that would provide rapid turnaround and high capacity on a high capacity instrument, can be lab or point of care, depending on the use case for this assay, provides quantitative results where we can use to compare trends and compare across patients, differentiates IgM from IgG and IgA, and I think above all, most importantly, the perfect serological test chooses a target where quantitative levels actually correlate with protective immunity. And so while at the current moment, we can probably check off the first 4 or 5 of these different boxes with a single assay, none of the assays that are currently in use right now are known to correlate with protective immunity, or at least been shown definitively to do that. So therefore, we are still waiting on the perfect serologic test, and that will take at least several months more work efforts to determine what those correlates are. So lastly, the main takeaways are that serologies are absolutely a critical part of controlling the COVID-19 pandemic. As Dr. Kritzis will talk about, they serve many different roles. Currently, they serve the role of diagnosing potentially as an adjunct for active infection, but also determining prior exposure. There are many different types of assays that target different viral proteins and have different performance characteristics and different use cases. And it's very important that providers who use these tests try to get a sense of what those different characteristics are. And lastly, that test interpretation should be done very thoughtfully in order to prevent erroneous medical decision-making based on assumptions that may or may not hold for this particular assay. So thank you very much for your time.